Coming to the treatment, once you are certain about whether it is primary, secondary or due to the other causes. Now if it is primary, so you have to start the treatment as early as the child comes to you. I mean to say, if it is in the first week of delivery or if an obstetrician or the pediatrician has referred to you, start the treatment then and there itself. First is to counsel the mother regarding what is the cause and how it can be treated. Usually it can be treated by plasters and is some small minor surgery most of the time. In olden days or over a period of time, kites method is very it was very important, and it was the method which has been followed for almost like 40 years, but presently we are following the Ponseti casting. Ponseti casting, why it is important? Because it has got more success rate. Ponseti casting, in which we call the child every week and change the plaster serially with serial correction of the deformity. The way in which we correct the deformity is we usually do the adduction, then the varus and last the equinus. If you are not going in the same order, there will be complications and foot might not get corrected or it might prolapse. In the last period, I mean to say, once most of the deformities is corrected, before the equinus is being corrected, we do tenotomy and put the plaster for 2 weeks, and after the plaster is being removed, we call the child to reassess. If the child is okay, we have to maintain the deformity correction, in which we put some splints, that is called Dennis Brown splint. DB splint we continue till the child starts walking. Once the child starts walking, in the night we continue DB splint for 1 year, and in the daytime you put the CTEV shoes. For the things in which the serial casting by Ponseti or kites has not been beneficial, we do some procedures either by a small soft tissue procedure or a bony procedure. The soft tissue procedure is posteromedial release of soft tissue, tendons, or the bony procedure like Dillman's procedure, or some of the osteotomies in which we do the wedge osteotomy, or the orthodesis in which we fix the joints and correct the foot. Usually the bony procedures and the osteotomies we take up after 3 to 8 years. Usually 3 years is the soft tissue time and 8 years, after which we do the bony procedures. Coming to the complications, if the proper method is not being followed in manipulation and casting, the foot might be resistant, it might become resistant to become corrected, or it might be a rocker bottom foot in which it looks like a rocker, in which the correction can be difficult later on. Some of the children, after the correction, if they are not following the DB splint or the CTEV shoes, there might be chances that the child might come with a relapse, in which we follow again serial casting and tenotomy. Thank you.